All right, whenever you're ready.
So welcome to ACVNU Journal Club today. My name is Lucy Kopecny and I'm an ACVNU resident. The article that I'm discussing today is a retrospective study on polypoid cystitis in 112 dogs from North Carolina State University from the Journal of Veterinary Internal Medicine. As background, we know that polypoid cystitis can occur due to inflammatory and hyperplastic reactions to chronic mucosal irritation of the bladder, with the most common causes based on studies so far in dogs, as well as clinical experience, being urinary tract infections and cystolithiasis. And polypoid cystitis can cause a range of clinical signs, including lower urinary tract signs such as hematuria, polarchiuria, and stranguria, with previous studies suggesting that hematuria might be most common. It's been suggested that polypoid cystitis could represent a pre-neoplastic condition or predisposed to neoplastic transformation in the future. And there has been one case report of neoplastic transformation of polypoid cystitis in a dog, which was reported in 2021 in the Journal of Veterinary Internal Medicine. And the image on the right of the screen in A shows an area of polypoid cystitis, but in B shows the area of malignant transformation. One of the previous larger studies of polypoid cystitis in dogs focused on 17 dogs and was published in 2003. In this study, 88% of dogs were female and 82% presented for macroscopic hematuria, with their clinical signs ranging in duration from 2 weeks to 3 years. Urine culture was positive on presentation in 10 of these dogs, with Staphylococcus and Proteus species and E. coli and Enterococcus reported relatively equally commonly. In that study, when all bacterial isolates were considered both at presentation and follow-up, Proteus was the most common in 23% of dogs, but E. coli and Staphylococcus were also relatively similarly common. And of course, E. coli and Staphylococcus are common causes of urinary tract infection in dogs, as are Proteus species. In this study, there was a macroscopic mass present in 15 of the dogs, and it was located in the cranioventral or ventral portion of the bladder where the location had been reported. 7 of these dogs had cystolithiasis, with the cystitis being reported in this study being struvite as well as calcium oxalate where it was analysed. We have limited data on polypoid cystitis in dogs in the veterinary literature, and that's one of the reasons why I was interested in looking at this study. In humans, polypoid cystitis can occur for a range of reasons, including long-term indwelling urinary catheters, long-term urinary stents, and radiation treatment for prostatic cancer. The objectives of this study were to improve the understanding of the diagnostic features associated with polypoid cystitis in dogs, and the dogs included in the study had both histologically confirmed diagnosis of polypoid cystitis or a clinically supported diagnosis. Now, this was a retrospective study that was a case series. It included client-owned dogs with a diagnosis or presumptive diagnosis of polypoid cystitis at North Carolina State Veterinary Hospital between January 2004 and October 2020. And they identified these dogs searching a number of terms in their medical records. Dogs were included if they had histopathologic evidence of polypoid cystitis or imaging and other features that supported a presumptive diagnosis, which included a cranioventral bladder mass or projection, having a history of urinary tract infection or cystolithiasis, and a disease course that wasn't consistent with neoplasia. So dogs that had a presumptive diagnosis had to survive more than a year after they had been diagnosed with polypoid cystitis to suggest that neoplasia would be very unlikely. The histopathology was reviewed by board-certified veterinary pathologists, and the criteria used for diagnosis of polypoid cystitis was that there were microscopically detectable polypoid projections of mucosa and stroma into the lumen, epithelial proliferation, stromal edema, inflammation, stromal hemorrhage, and hemosiderin accumulation. They also extracted DNA from fixed tissue samples were available for PCR for detection of the BRAF mutation, which were then scored as having the mutation detected or undetected in an effort to better exclude patients with urothelial carcinoma. The data collected included age at onset of clinical signs, breed, sex, body weight, clinical signs and their duration, what previous treatment patients had undergone, culture results, imaging findings, the results of BRAF screening, any treatments that had been performed, histopathology findings, and case follow-up. Although not described in the materials and methods, they did use just descriptive statistics in this study. In terms of the patients that they included, they had this flowchart. So they identified 135 dogs in their medical record system that were diagnosed with polypoid cystitis, and excluded some of these due to duplicate records, an incomplete record, or poor survival. So they didn't meet the inclusion criteria if they had a presumptive diagnosis. And they then had 59 dogs with histologically confirmed polypoid cystitis and 53 dogs with a presumptive diagnosis. Of the 112 dogs that were included, 64% were female and 35.7% were male. And most dogs, or almost all dogs, were purebred, with Labrador and Retriever and American Cocker Spaniel being the most common breeds in this study, although they were still only present in smaller numbers. The median duration of clinical signs in dogs of this study was 84 days, although with quite a wide range from 1 to over 1,000 days. And these dogs presented with macroscopic hematuria in 37%, stranguria, polarchiuria, recurrent urinary tract infection, urolithiasis, and inappropriate urination in the house. Polypoid cystitis was an incidental finding in 13 dogs that were included. These were dogs that were being investigated for other diseases with polypoid cystitis being found on their workup, but not their primary reason for presentation. Urine was collected for urinalysis at admission from 105 of the 112 dogs, with hematuria present in just over 64% of the samples, pyuria being present in 35% of the samples, and bacteriuria in 27% of the samples. Urine samples from 80 of the 112 dogs were submitted for urine culture, and 33% were positive for bacterial growth, but 35 dogs had been administered antibiotics within 2 weeks before presentation. And when they reviewed their medical records from the referring veterinarians, 54% of dogs had bacterial growth. Including these initial samples as well as cultures performed at follow-up, the most common bacterial isolate was E. coli, followed by Enterococcus and Staphylococcus pseudointermedius. Imaging findings in these dogs were based on abdominal radiographs as well as ultrasound. Radiographs were performed in 26 dogs with radiopaque cystic calculi identified in 16, and then abdominal ultrasound was performed in most of the dogs, which showed polypoid structures, as you can see in these ultrasound images from the study on the right. Broad-based masses and bladder wall thickening less commonly in about 25% of patients, bladder wall irregularity in 2%, and a quarter of the dogs had cystic calculi. Interestingly, the location of the polypoid masses was in the cranioventral or ventral region in 80%, but in the trigone in 13%, which I found interesting given that it's most often that we suspect that it's a urothelial carcinoma if we find a mass in the trigonal region. 48 of the dogs had cystoscopy with polypoid masses identified in 89% of these masses and 79% having multiple masses. In the dogs that didn't have polypoid masses identified, they had areas of irregular thickening in the affected area. And these are again some cystoscopic images showing polypoid changes in the urinary bladder from the dogs included in this study. Histopathologically, histopathology, was performed on biopsy specimens in 70 dogs, with 38 of these obtained cystoscopically, 27 surgically, and then 5 post-mortem. And the findings were, as expected in dogs with polypoid cystitis, with inflammatory infiltrates present in 65%, mostly varying from mild to moderate, and most dogs having predominantly lymphoplasmacytic infiltrates, although neutrophilic infiltrates were present in 25% of dogs and eosinophilic in 8%. Other common findings were hyperplastic epithelium in 60% of dogs, submucosal hemorrhage in 50%, submucosal edema, papillary projections, Brun's nest, and then other less common findings in a smaller number of dogs were epithelial ulcerations or erosions, mucoid metaplasia, and epithelial dysplasia. Testing for the BRAF mutation was performed in 27% of the dogs using DNA from the formalin fixed samples and was negative in all dogs. The most common treatment that dogs received was antimicrobial agents, which were given to 65% of dogs, with amoxicillin clavulanate or amoxicillin most commonly administered. Surgery was performed in 36 of the dogs for polyp removal, cystotomy and stone removal. So the most common reason was for both cystotomy and stone removal, and partial cystectomy, and then one dog each had a ureteroid neocystostomy and unilateral nephrectomy with bladder polyp removal. The ureteroneocystostomy was performed due to a ureteral obstruction secondary to the presence of a polyp, and the dog with the unilateral nephrectomy had severe pyelonephritis, and as a result of that, nephrectomy was deemed most appropriate. Cystoscopy was performed to remove polyps from 15 dogs, using either biopsy snares in 10 dogs or laser ablation in 5. 23 dogs were given anti-inflammatory agents such as NSAIDs or prednisolone. NSAIDs obviously most commonly used in 19 of the dogs. Overall, the suspected cause of polypoid cystitis was chronic or recurrent urinary tract infection in 54% of the dogs, cystolithiasis in 33.9% of the dogs, and the cause wasn't able to be identified in just over 12% of the dogs, but most of these dogs did not present to the hospital for urinary tract disease. So we can see that the most common causes, as suggested by other literature, is chronic or recurrent urinary tract infection and cystolithiasis. The median duration of follow-up in these dogs was 8 months, with a range from 1 month to almost 8.5 years. And in that time, 23 dogs had recurrent lower urinary tract disease, infections, or recurrence at a median of 8 months, but range from 3 months to 4 years. There was follow-up ultrasound available in 50 of the 101 dogs that had an initial abdominal ultrasound, with polypoid cystitis resolved in 22 dogs, improved in 6 dogs, and static in 22 dogs. And no dog was known to develop malignant neoplasia in the urinary tract following their diagnosis of polypoid cystitis. In the group of dogs with a presumptive diagnosis of polypoid cystitis, They were followed from between 12 months to 8.4 years, with a median of 1.8 years of follow-up, suggesting that neoplasia was truly unlikely in this group. In dogs that underwent surgery for polyp removal, 6 of the 48 had recurrence of lower urinary tract diseases, infections, or cystitis, but didn't have polyp recurrence. And again, in dogs with polyp removal during cystoscopy, only 4 of them had recurrent signs of lower urinary tract disease. And persistent polypoid cystitis was uncommon in dogs that did have recurrent disease. Overall, this study is a helpful addition to the literature on polypoid cystitis, given that there's limited data available for dogs with this disease. I think some of the things that I found interesting going through this study is that although female dogs were more commonly affected than male dogs, there wasn't a marked sex predisposition, despite urinary tract infection being more common in female dogs. So you can see again from this table from the study that male castrated dogs comprised 34 dogs and female spayed 64 dogs. The reason for female dogs being more common than male dogs, but male dogs still being frequently represented in this population wasn't determined. It's possible it could be related to being a secondary or tertiary referral population, or that or other factors that weren't identified. The location of the polyp was most often in the cranioventral bladder, but in 9 dogs it was located in the trigone. And I think that was, this is very helpful information to have, in that, often when we see patients with a trigonal mass, most suspicious that is urothelial carcinoma, but this study supports that there is still a possibility of that being polypoid cystitis in some dogs. The polyps that were identified were polypoid structures in 40%, or broad-based masses in 26% of dogs. So again, useful information in a clinical setting on the appearances that we might expect in these dogs. E. coli was the most common bacteria identified in this group of dogs, in 53%. Previous studies have suggested that there was a relationship between Proteus and polypoid cystitis, given Proteus had been identified frequently in dogs with polypoid cystitis. But in this study, only 4% of positive urine cultures were positive for Proteus. It could be that in those previous studies, it was by chance that more dogs did have Proteus species. Or, in a different group of dogs, we may see Proteus species playing a bigger role, but certainly it seems like we're most often looking at E. coli, which is consistent with the most common bacteria we see in dogs with urinary tract infections. Of dogs that underwent cystoscopy, 89% of them did have overt polypoid masses, and dogs without polypoid masses had thickened mucosa and nodular irregularity of the mucosa, which could be just part of the disease spectrum. So these dogs may be at an earlier part of their disease compared to the dogs that had overt masses identified. Based on this study, we can see that polyp removal by surgery or cystoscopy is possible, but unfortunately there wasn't data to suggest what the best approach to treatment would be. And I think importantly, no evidence of malignant transformation in dogs in this study, including in those with persistent polypoid cystitis, although that group of dogs was smaller in number. I think the main limitations of this study are related to it being a retrospective study where, of course, diagnostics, treatment, and follow-up aren't standardized. And some of the findings could also be influenced by it being a secondary or tertiary referral population, particularly. I'm not sure whether that affected the sex bias in this group of dogs. It seemed, although they did include dogs with a presumptive diagnosis of polypoid cystitis, it seemed unlikely that these dogs had urothelial carcinoma, based on prolonged follow-up times with no evidence of neoplasia. They did perform, of course, BRAF testing to help exclude urothelial carcinoma in these patients, but interestingly, the single case report of the dog that did have suspected malignant transformation of polypoid cystitis to transitional cell carcinoma that I mentioned earlier in this talk lacked the BRAF mutation. So always possible that dogs with malignant transformation may not have that mutation present. I think although this study certainly was helpful, it still left me with a lot of questions about management of polypoid cystitis, such as, what is the best treatment of polypoid cystitis, and does it change depending on the polyp size, cause, or location? Particularly, in which patients is medical therapy, so NSAIDs or prednisolone, plus treatment of the underlying disease process, whether that's a urinary tract infection or stones, or surgical. So which patients is medical therapy most appropriate for, and which patients is surgical or cystoscopic removal of the polyps most appropriate for. I was also curious about the agreement between ultrasonographic and cystoscopic findings. I've certainly had patients where ultrasonographically there seems to be, more moderate proliferative changes that on cystoscopy was less notable, which of course can also relate to bladder distension. And, another question I had was what stone types were associated with polypoid cystitis in these dogs, given that stones were the second most common cause. I typically often associate, or see clinically polypoid cystitis more often associated with stones that are more irritating to the bladder mucosa, such as calcium oxalate stones, and of course sometimes struvite stones when they're associated with urinary tract infections. But certainly would be helpful to see, what some of those associations were, including, any associations with stone size and number. And with that, I'll just ask if anyone has any questions.
Hey, Lucy, nice job. I was interested in the choice of therapy that they gave these dogs. If looking at their antibiotics, a lot of the dogs were receiving Clavamox, um, amoxicillin, things that we don't really consider to have good tissue penetration. And with so many dogs having UTIs as a potential cause, that's not the antibiotic that I would certainly put a patient on if I thought that the polyps were secondary to infection or if they were harboring any bacteria. I'd want something with actually decent tissue penetration. So I wasn't sure what people had thought and what the practice might be amongst the people on the call for antibiotic therapy when they see a patient with polypoid cystitis, and what antibiotics are they turning to? Has anyone had any success with just using antibiotics without removing them? Just doing a prolonged course of therapy? I'm interested to see what people have been doing.
I will say, JD, this is Allie. This was definitely a concern with putting this paper out, but you have to, like, most of these dogs were in the early 2000s when we went back retrospectively, because this was a resident project years ago. And so we certainly have changed our practice since this paper. So I absolutely agree with you. I don't think we would ever choose Clavamox at this stage. But yeah, that was certainly the concern with this paper was it's actually pretty old, the population we had. And so that's why also so many of them had surgical removal over cystoscopic removal too.
Gotcha. Thanks so much, Allie. Yeah, I think it's, we've had some cases, I'm sure everybody has, where you have one or two enormous polyps, and then sometimes you have 15 polyps in the bladder. And I don't have any idea of what factors might be associated with getting the huge polyps that are few in number versus the cases that have tons of polyps in their bladder and they're all pretty small. Maybe it's just individual patient, but I don't know if there's factors that might drive one or the other. I don't know if anyone has seen that association, but it is kind of quite different. Sometimes you get that polyp that's so big you have to transect it to get it out of the urethra. And then many other times they're like what was shown in the image in the paper is just these small little blebs that you can almost just rip them off with biopsy forceps at the same time.
JD, this is Jenna. When I looked at this paper, I had similar questions about antimicrobial therapy. The other thing that we have found, it seems like, everything comes in waves. We've had a lot of polypoid cystitis the last couple months. And some of these dogs we've followed now for quite some time. And one dog in particular really seems to be NSAID responsive. And so this particular dog, at one point in time, cultured positive, and we've done repeat cultures many times subsequently, and it's been negative. And I don't know if it's something similar to the proliferative urethritis, where it's, truly some immune-mediated component secondary to infection. But what's strange, this dog had really profound gross hematuria, has been scoped, and then responded beautifully to NSAIDs. And the owner, for a variety of reasons, kept on stopping the NSAIDs. And it was like clockwork. Stop the NSAIDs, the dog would have recurrence of hematuria, no dysuria of any kind, but hematuria was the chief complaint. And then we would say, well, restart the NSAID. We've re-imaged the dog, and the dog still seems to have bladder irregularities. He's BRAF negative, and again, we've followed him now for quite a long time. And we've told her if this is really bothersome, we can, we can get rid of him, but she hasn't wanted to do anything additional. And so I don't know. That's a little bit interesting to me too, and I don't know if you have any additional comments.
Yeah, we've followed these patients, and we've even had a couple that had just really atypical cysto findings as well, where we've talked with Rachel and we've gotten additional cytokeratin staining done, immunohistochemistry done. We've done BRAF immunofluorescence on the tissue, and we've gotten some like Brun's nest inversions and things like that that grossly look the same. And I think, for a lot of people that are unfamiliar, polyps can look like cancer, but then once you've seen a couple, you start to feel pretty comfortable that you think that these are just going to be polyps cystoscopically. But every now and then the histo does certainly throw a monkey wrench in the plan, and whether that's because it's a more chronic lesion, whether it was maybe something that had more significant inflammation, and so maybe there's more dysplasia associated with it at the onset. You can imagine if there was maybe a big stone that was really rubbing the bladder raw, maybe that would cause a polyp to develop faster or maybe more aggressively. It's really interesting. I think there are a lot of different factors, and because it's almost a common result to cystitis, whether it's UTIs or whether it's stones that are causing cystitis, the bladder is reacting in a way that is just a bit atypical. Like even if you look at the colonic polyps, those are patients that are generally not having chronic colitis. They're just its own disease in many of those patients. So why the bladder decides to react that way and is a reason I don't understand. But I agree, there are patients that we kind of monitor that they have mild changes and it doesn't really change over time. Whether an NSAID helps with that or not, we certainly monitored patients that are infection free now and their small polyps just hang out and don't seem to get worse and haven't seemed to get better. And we just kind of watch and observe and have not pursued removal because we didn't really have a reason to, other than just to exclude that they were in fact neoplastic, but we had low suspicion for that. So they can kind of do what they want to a large extent, which is cool, but also kind of annoying to not be able to know the exact history and expectations that you might have for these lesions.
Just out of interest, when you are removing polyps, are you removing them with like a cautery type snare or with laser?
We would potentially do a cautery snare for majority of them, and we would use our resectoscope for some. A laser also works. Having the resectoscope, that would be my preference because you just get better control over the tissue. You're able to kind of pinch the tissue between the electrode and the scope and get a little bit better purchase. Using a laser, in my experience, as you start to cut through it, it becomes less attached. So now the tissue is more mobile and it ends up becoming a bit more of a moving target. So we don't do that as much here at Friendship. We tend to use the cautery snares as the main method if they're big enough, and then if they're small, we just might use our septoscope to get them off, or even just shave off the superficial mucosa as needed. But I'm interested to see how other people might be doing it too.
Yeah, we also use our resectoscope a lot too. I would say like I just had 2 last week. Interesting. So I feel like I'm like Jenna, that they come in waves. Use a variety of different tools, I think, based on the what they look like and how broad their bases are. I've had a lot, and I don't know if JD, if you've had similar, where I don't even need the cautery snare and I can just snare it and just pull it off the wall, and it basically comes completely off.
Oh yeah, for sure. There are
Yeah,
some patients that like we're trying to attach the electricity to the snare, and by the time we look up, we've already kind of ripped it off the wall.
yeah, yeah.
And small ones, you can even do that with biopsy forceps as well too.
Yeah, yeah, and sometimes I'll use even just a basket, because sometimes you can get the whole thing in the basket really easily. But then, so we use a variety of snares, baskets, cautery snare if they have a little bit of a bigger base, the resectoscope, and then I've also had some where the really small ones will pull out the laser and just like touch it with the end, like the laser, and it seems to make them regress. But that's really just the small ones where you can't even really grab them. You just hit them with the laser in a really low setting.
Yeah, and thank you. Not sure if anyone has any other comments or whether we finish up.
Yeah, I guess if everybody is good, then we can go ahead and end it here then. Thank you guys for coming. And thank
Yeah,
you, Dr.
thank you.
Kopecny.
Yeah, thank you so much. I'm sorry it had to be delayed.
Oh, no problem at all. Have a great afternoon, everybody.